Good morning and assalamu alaikum everyone. My name is Dr. Mishal Munir. I am currently pursuing my journey for internal medicine residency, and today we'll be discussing about amyloidosis, a closer look at the silent intruder. I will be talking about what is amyloidosis along with the types and classifications. Furthermore, we'll be discussing the pathogenesis of amyloidosis, the first line steps in diagnosing amyloidosis currently that are being used, few diagnostic modalities, and apart from that, the prognosis, staging, the pre-treatment evaluation when it comes to amyloidosis in certain trials that are going on at the moment. Apart from that, we'll be talking about the prognosis of amyloidosis as well, based on the systemic amyloidosis and trans-threatened amyloidosis majorly. So coming to the question that what is amyloidosis, it's basically a disorder that's characterized by deposition of certain misfolded proteins. Now, when they aggregate, they are going to be forming insoluble fibrils, and that is when there is going to be tissue damage and functional compromise that we will be seeing. So talking about the pathogenesis of the major forms of amyloid fibrils, now if there's a production of abnormal amount of proteins happening, there are going to be two causes to that. One is that either there is going to be acquired mutation, and the other is if there's a chronic inflammation going on. So if there's a chronic inflammation going on, let's say if the patient comes up with a chronic disease, for example, rheumatoid arthritis or ulcerative colitis or Crohn's disease, any sort of chronic inflammation that is going on in the body, the macrophage activation leads to interleukin 1 and 6. Now, the liver cells in response to that produce SAA protein, which due to some limited proteolytic activity leads to aggregation of AA protein. Another way around is that if there is an acquired mutation. Now, let's say if the patient has some sort of plasma cell dyscrasia, for example, there's some monoclonal gammopathy of undetermined significance, some sort of monoclonal B lymphocyte proliferation, that leads to the production of immunoglobulin light chains. And due to the limited proteolytic activity, that also leads to the formation of AL protein aggregates, which is the light chain protein aggregates that are going to be forming. Then let's say if it's a native folded protein and there are amyloidogenic intermediates which are formed. Example, misfolded proteins form. So monomers, they assemble to form beta sheet structures, and that would also lead to fibril aggregates. The fourth way is that there's a production of mutant protein. For example, if there's trans-threatened mutation happening at the TTR protein leading to the mutant trans-threatened protein, which aggregates and forms the ATTR protein. So summing up the whole thing, there are four ways how amyloid forms. Let's say the protein structure is normal, but this normal protein structure is present in really high abundance. Then let's say the protein structure is normal, the concentration is normal, but there is a limited proteolytic activity that is seen, which leads to prolonged period of time this protein is present in the body. And the third thing is that if there's an aberrant protein, which with highly amyloidogenic properties that I've mentioned before as well. And the fourth thing is that there's a failure of degradation mechanism, which is seen. So moving on to the classification of amyloidosis. Now, there are two subtypes. Basically, there's systemic amyloidosis and there is trans-threatened amyloidosis. Out of the systemic amyloidosis, there are further two subtypes. That's AL amyloidosis and AA amyloidosis. AL amyloidosis, as the alphabet L denotes, it has majorly the light chain protein deposition that is over there, whereas AA amyloidosis majorly have amyloid A protein deposition, which is present over there. Now, the disease etiology of AL amyloidosis is that I've mentioned before, there is some sort of plasma cell dyscrasia, which leads to increase in the immunoglobulin light chain, and then that is going to be affecting multiple organs. For example, it will be affecting kidney, heart, and liver majorly. And the median survival of AL amyloidosis is 1 to 3 years, sadly. Then we have AA amyloidosis. Now, AA amyloidosis normally has the protein in abundance, that is the amyloid A. And this, as I've told before as well, is linked with systemic autoimmune or infectious disease or any sort of chronic inflammation going on in the body. And then renal dysfunction is the specific feature which is highlighted with AA amyloidosis, and the median survival is 11 years, as majorly it affects the kidneys and not it doesn't affect multiple organs at the same time as compared to the AL amyloidosis. Then we have trans-threatened amyloidosis. Now, this is also divided into two subtypes. There is ATTR-M and ATTR-WT. This is based on that ATTR-M has mutation of the TTR protein, and this is basically common in African men, African Americans majorly, and the median survival is 2 years. Whereas the ATTR-WT is majorly associated with an age group which is more than 75 years, and it's associated, the specific features would be carpal tunnel, and this is a male-dominating disease, and the median survival that is seen so far is 4 to 6 years. Now, what organs are affected? Amyloidosis majorly affects multiple organs. As you can see, it will be affecting the kidneys, leading to renal failure and proteinuria. Then apart from that, there will be nervous system, autonomic and peripheral nervous system, both that is going to be affected over there. This carpal tunnel syndrome along with cardiac, heart being affected the most, irregular heartbeat and heart failure, nausea, vomiting, constipation, diarrhea, that includes the GI system as well. And along with that, we have patients coming up with glaucoma, dark floaters because of the abnormal deposition in the blood vessels in the eye. So it's basically a disease which is affecting multiple organs. And one thing more, that cardiac involvement of amyloidosis is actually one of the biggest and the major prognostic factor when it comes to the prognosis of amyloidosis in any patient. We'll be discussing it in detail later in the slides further. Now we'll be talking about the clinical presentation of both the AL amyloidosis and TTR amyloidosis. Now, I will be differentiating both of these when it comes to their clinical features. AL amyloidosis normally comes up in age group that is more than or equal to 40 years. It comes up with various features of multi-organ involvement, and it presents with unintentional weight loss along with loss of appetite and fatigue. And then it involves a lot of organs that leads to waxy skin, easy bruising, enlarged muscles, comes up with macroglossia, deposition of amyloid in the deltoids, carpal tunnel syndrome. Then it has cardiac involvement, liver involvement, kidney involvement leading to nephrotic syndrome, and peripheral and autonomic neuropathy with impaired coagulation. Whereas in cardiac amyloidosis, the age group that is normally seen coming up with cardiac amyloidosis is more than or equal to 60 years. Patient presents with syncope or presyncope, and there's a big difference in both of these. Now, cardiac involvement is present in AL amyloidosis as well, and it is obviously seen in TTR, that's amyloidosis as well. But normally, patients with the light chain amyloidosis, they infrequently develop high degree atrioventricular blocks or symptomatic sinus node dysfunction. Whereas a patient, an old age patient, more than 60, coming up with TTR amyloidosis normally presents with an advanced AV block on their first presentation. Along with that, there will be restrictive cardiomyopathy, which is going to be seen with right ventricular failure and showing signs and symptoms of low cardiac output. For example, this lack of capillary refill and low pulse pressure. Furthermore, there will be autonomic or peripheral nerve disease that will be seen. Patients normally come up with bicep tendon rupture, there'll be spinal stenosis, and these are relatively common in patients with the WT-ATTR amyloidosis subtype. So we'll be moving on towards a step-by-step approach to diagnosis. What are the steps that we're going to be taking if we're suspecting a patient who comes with signs and symptoms of amyloidosis? Now, this is that we will be doing certain tests. The first and the foremost test which we're going to be doing is that serum protein electrophoresis with immunofixation, urine protein electrophoresis with immunofixation, and serum free light chain ratio is going to be seen. Now, the purpose of all these tests is in order to see if a monoclonal protein is present or not. If the monoclonal protein is present, then that means that we will be reviewing both the abdominal fat pad aspirate and we'll be taking a bone marrow biopsy. And there's a reason that we take abdominal fat pad aspirate instead of taking a biopsy sample from the affected organ or from any affected organ. That is that there are a lot of consequences if we take a biopsy sample from the affected organ, example kidney and liver, because there are a lot of chances of bleeding. So the first and the foremost thing that we do majorly is that we go for the abdominal fat pad aspirate and bone marrow biopsy. Now there are two situations ahead. Either the amyloid is detected, or if the amyloid is not detected. If it's not detected, so it's unlikely, but if still there's a clinical suspicion, then we'll uh, go with the idea of taking a biopsy sample from the affected organ. For example, it's kidney or liver. If the amyloid is detected, then we actually see that the amyloidosis is confirmed, and we go with certain tests which include mass spectrometry, which is the preferred one. Then followed by that, immunoelectron microscopy and immunohistochemistry, which will be showing the Congo red staining and the apple green birefringence with the immunoelectron microscopy. These are the findings that will be these are the findings that will be present if amyloidosis is present over there. But if there is no monoclonal protein present, then what are we going to do ahead? So if it's not present, then we actually see that what organ involvement is suspected. For example, is the heart affected? If the heart is affected, then obviously there's a cardiology referral for advanced imaging and for further diagnostic evaluation that is going to be taking place, but we will be talking it in detail afterwards. Apart from that, if there is kidney, nerve, or liver involved, then again we'll be going with the abdominal fat pad aspirate, and if negative, then the biopsy of the affected organ will be done. If amyloidosis is detected, then we'll be heading with the following tests, which includes the mass spectrometry, the immunoelectron microscopy, and the immunohistochemistry. But if it's not detected, then that means that amyloidosis is unlikely. So we've discussed the diagnostic modalities before, but again, the tissue biopsy that I've mentioned before, that we take fat pad aspiration biopsy because liver, renal, rectal biopsy can be complicated by serious bleeding. So tissue biopsy is the initial biopsy technique. And monoclonal protein testing, as I've told before as well, that we have to see the monoclonal protein, whether it's present in the serum, urine, or both. And for that, we do these tests. Apart from that, we need to see the quantity of the serum free light chain ratio, which is suggestive in patients for AL patients, AL amyloidosis who do not have monoclonal protein by immunofixation. Now, there's a diagnostic criteria for systemic AL amyloidosis, which is basically that it needs to have all of the following. It needs to actually have the presence of amyloid-related systemic syndrome. That means it needs to have multiple organs being affected, which includes renal, liver, heart, GI, and peripheral nerve involvement. It needs to actually have positive amyloid staining by Congo red staining. Um, in any tissue, for example, a fat aspirate, a bone marrow biopsy, or an organ biopsy that we're doing, then there needs to be an evidence that amyloid is light chain related, that we are going to establish by direct examination of the amyloid using mass spectrometry, and that is why we do it, or immunoelectron microscopy. And then there needs to be an evidence of a monoclonal plasma cell proliferative disorder of any form, some sort of plasma cell dyscrasia that's taking place. There's an abnormal free light chain ratio that we're seeing. There is a serum or urine monoclonal protein that's present, or there are clonal plasma cells in the bone marrow. So this is basically an international myeloma diagnostic criteria for diagnosing systemic AL amyloidosis. So this is the histopathological slides. We see that a renal biopsy sample showing Congo red staining, which is quite evidently showing the amyloid fibrils there denoted by this blue arrow. And then we see the apple green birefringence when we under the polarized light. The specific diagnostic tests for cardiac amyloidosis. Now, the question is that if the major organ that is being affected is the heart, as I've mentioned before in the slide, what we're going to do ahead. So the first and the foremost thing, or the initial imaging test of choice, is the echocardiography that's going to be done for diagnosing cardiac amyloidosis. And what we're going to see in that is that there is going to be an apical sparring of longitudinal strain. That is an important feature to that. Apart from that, we go ahead with a cardiovascular magnetic resonance, that's the CMR, which basically provides a detailed assessment of all the cardiac structures and function, as well as it tells the characteristic of the myocardial tissue as well. It can detect whether earlier cardiac amyloidosis before even the development of any left ventricular hypertrophy. But another test which is very important in identifying ATTR amyloidosis, and it's very important and it has a pivotal role, is basically the bone tracer cardiac scintigraphy. I will be discussing it in detail in the next slide. So this is basically what bone tracer cardiac scintigraphy is. Okay, I will be discussing this diagram that you see. So what it is that we have a whole body perigony visual scoring of cardiac uptake, and we do the 99M tactinium scintigraphy, in which we see that in grade 0, it represents no cardiac uptake. As you see that there is no a black spot or the uptake that is going to be seen at the cardiac region, there's none. Grade 1 represents mild cardiac uptake, as you see it over there. And then if you move towards grade 2, it represents a greater um, cardiac uptake, greater than that in the bone, as you can evidently see with this black spot over there. And then with the grade 3, it represents substantial cardiac uptake with only weak or no signal evident uptake in bones. As you can see that the whole in the grade 3 picture, you can see that there's a massive amount of uptake by the heart that's seen, and the bone one is like negligible. But over here, as you go towards grade 0, the bone uptake is more than the heart uptake, and the heart uptake, cardiac uptake, is nearly negligible. So what it actually denotes, all of this, is that any presence of grade 2 or 3 positive bone tracer cardiac scintigraphy in a patient without any monoclonal protein. For example, the free chain ratio is normal. The serum and the urine immunofixation results are also normal. Now, if this is the case, and there is a presence of grade 2-3 positive bone tracer cardiac scintigraphy, then that is that it is highly specific for ATTR cardiac amyloidosis. And this is actually sufficient to diagnose for ATTR cardiac amyloidosis without any sort of tissue biopsy. So this is why this bone tracer cardiac scintigraphy holds this much of importance when it comes to diagnosing ATTR amyloidosis. Now, moving on to its treatment, we will be, before starting on with the treatment, we'll be discussing the pre-treatment evaluation. Now, what we're going to do is assess the patient. We will be also seeing what are the organs that are involved. And then there's another thing that's called staging. We'll be staging the amyloidosis based on a staging system, which I will be discussing ahead in the slides. That all of these models, they basically constitute the major prognostic factors will be the troponin and the brain natriuretic peptides, and there are certain reference ranges which are different in all these models, but the main idea behind all these models is that the staging is done on the basis of the levels of the cardiac troponin T or troponin I along with the brain natriuretic peptide. And as the stage increases, as it is clearly seen from the data that's present in front of us, that as the stage increases, the hazard ratio increases, and as the hazard ratio increases, that clearly denotes that the chances of mortality in a patient increases. I will be discussing in detail Mayo 2012 model, which is the recent most. As you can see that there's a troponin levels, which are going to be denoted by cardiac troponin T level more than 0.025 micrograms per liter, or if the higher sensitivity, that means the cardiac troponin T is present more than 40, then there's brain natriuretic peptides. There's a reference range given of BNP more than 400 and NT-pro BNP more than 1800 in nanogram per liter. And the third criteria that they've added in the Mayo 2012 model is the difference between the involved and the uninvolved serum free light chains. That is more than 18 milligram per deciliter as a reference range. So as these values keep on increasing, the stage increases, and as the stage increases, if it's stage 1, if the stage it's 2, then it's 1.7 the hazard ratio. If it's stage 4, it's 6.3, then that definitely means that the chances of mortality in the patient increases as the stage increases. Then we'll be talking about the treatment and the management of AL amyloidosis. Now, if the patient like there's a patient who comes with a newly diagnosed systemic AL amyloidosis, we will be assessing if the patient is a candidate for the transplant or not. If the patient is eligible for an organ transplant, what we'll be doing is that we'll be giving an induction therapy with 2 to 4 cycles of bortezomib-based regimen. What is bortezomib? It's basically a proteasome inhibitor. And apart from that, we'll be doing the transplant with the melphalan, and melphalan is basically an alkylating agent, and then we're going to be assessing the patient at the 100-day post the transplant has occurred. And what we'll be seeing is that if the free light chain difference between the involved and the uninvolved is less than 40 or more than 40, and if it's less than 40, we'll observe the patient until further progression takes place. And if the results are more than 40 already, then we'll be going towards an alternative systemic therapy for relapsed or refractory disease. Now, I'll be discussing about the systemic therapy that we're using for relapsed and refractory cases of AL amyloidosis later. But first, we'll be talking about those candidates who are not eligible for transplant. So we're going to be planning 4 to 6 cycles of a bortezomib-based regimen and we'll be assessing the response prior to each cycle. We will be seeing if there's a progression that is happening at any time or if there is no progression. If there's a progression happening, again, we'll jump on towards the systemic therapy for relapsed refractory cases, which includes daratumumab-based regimen. It's basically an anti-CD38 monoclonal antibody that we're giving. Then it also includes the immunomodulatory derivatives, which includes lenalidomide, pomalidomide, and thalidomide. We give these immunomodulatory derivatives in combination with dexamethasone and cyclophosphamide. And apart from that, we also give bortezomib, which is a proteasome inhibitor-based regimen. So these are certain drugs which we are using, or certain regimens that we're using for people who have relapsed and refractory cases. But if the patient is not a candidate for a transplant, and we give them 4 to 6 cycles of the bortezomib-based regimen, and then there's no progression, then we see if the response milestone is achieved or not. Now, what is the milestone? Basically, that's if there's a 50% reduction in the free light chain difference of the involved and the uninvolved after 2 cycles, if it is less than 40 after 4 to 6 cycles or not. If it is, then we observe until certain more progression takes place, and if it's not, then we also again start giving the systemic therapy for relapsed and refractory cases of AL amyloidosis. Now, we'll be discussing about the updated treatment for trans-threatened amyloidosis. What we discussed before was for AL amyloidosis, that's light chain amyloidosis. Now we'll be discussing about the updated treatment. So for trans-threatened amyloidosis, the therapies that we're normally using at the moment is the RNA targeted therapies, which basically are responsible for reducing the formation of the TTR amyloid protein by stabilizing them and preventing the release of homologenic monomers. Example, we're using patisiran and vutrisiran. Then apart from that, there is a genetic editing option that we have, that we knock out the TTR production gene. And then there is stabilization of the trans-threatened tetramers, for which we're giving tafamidis and diflunisal. Other agents that are used for ATR amyloidosis, they include tolcapone, which is basically a drug that we all know that is used for Parkinson's disease, but it's basically a TTR stabilizer that actually mimics the effect of protective TTR T11M variant. So this drug is also shown to be a potent stabilizer in preclinical studies. And apart from that, again, inhibition of proteolysis is another thing, that direct extraction and macromolecule characterization of fibrils have been identified at specific amino acids. So this has been shown to be more intrinsically amyloidogenic and toxic. So we're using drugs which leads to the inhibition of proteolysis. And there's another interesting fact, that there are certain agents that have been found out that disrupt the fibrils. One of the agents is a doxycycline, which is an antibiotic which actually disrupts the fibril formation and mature fibrils, as well as it inhibits the MMP9. And then another interesting fact that I came across is that there are certain nutraceuticals. For example, we consume green tea in everyday life. And apart from that, we also consume curcumin. Now, what is curcumin? It's basically the turmeric that we put in a lot of Indian Pakistani cuisine and worldwide cuisines as well. It is used. So these two have been identified that they are responsible for disrupting the fibrils as well, and they suppress the markers of oxidative stress as well, and they actually prove to be beneficial for people with amyloidosis. KL101 trial is basically that this is a monoclonal antibody, which is actually that it promotes the phagocytic destruction and subsequent clearance of the amyloid deposits. And patients who have a relapse or refractory AL amyloidosis, they in those patients it has actually shown good effects, and it has actually shown that those patients had lengthy overall the mortality rate decreased in those, and there was a progression-free time period for those patients. The progression-free time period was more in those patients, but the phase 1A and 1B study showed this. The KL101, 301, and KL101, 302 phase 3 clinical trial is still underway to confirm these findings. So hopefully we'll be getting positive results soon as well. And then there is a bertamimab vital trial that is going on. This is also basically an investigational, it's a monoclonal antibody again designed to neutralize toxic light chain aggregates and deplete those amyloid chains via the macrophage-induced phagocytosis. So a confirmatory phase 3 randomized trial is still on its way. And so we're also, hoping for the result of the phase 3 to come back soon. Now, talking about the prognosis of various types of amyloidosis, for AL amyloidosis, it has a very poor long-term prognosis, as I've mentioned before as well. Thing is that there's a multiple organ involvement that is seen in patients with AL amyloidosis, so the mortality rate is really high. And the prognosis for the patients with AL amyloidosis is actually closely linked with the cardiac biomarkers, the staging of that, which I've mentioned before. As I told you that there are 4 staging models that are present, and the most important prognostic factor was the cardiac, those models constituted was cardiac troponin T and cardiac troponin I along with the BNPs. And then the other thing is the assessment of the organ involved. Um, the median survival for the AL cardiac amyloidosis that we've seen so far is approximately 5.5 years after diagnosis. So there have been 2 staging systems that have been proposed in patients with ATTR amyloidosis in order to see the prognosis in these patients. So as you can see in front of you that there are 3 graphs. The left, top left one, it basically shows the cardiac, the mortality, which is linked with the cardiac troponin T levels. And the right topmost graph shows the mortality rate linked with the BNP levels. The bottommost graph, it actually shows that the death percentage, as you can see on the y-axis, and that's linked with the staging. So as I've told before as well, that there are staging systems which are actually linked with the cardiac troponin T levels and the BNP levels. More of them means the stages, if it's stage 3, that means that the mortality is increased in those people who have stage 3 ATTR amyloidosis, followed by stage 2 and stage 1, and the mortality rate decreases as the stage decreases as well. So that's about it. I hope this session is informative for all of you out listening at the moment, and thank you so much for your time. Thank you.